Good morning, everybody. Welcome to Coffee and Cases. We're going to
Okay.
just give everyone another minute or two to jump in. I see that there are still numbers jumping up. But in the meantime, just a few reminders. So today's Coffee and Cases is going to be slightly different. We're going to try and build a little bit from the experience of the audience. So please feel free to jump in if you have something to add or an experience that you might have around the bleeding patient. We're going to focus on the trauma patient, but also on the postpartum hemorrhage patient because there's so much crossover between them. So obviously there are going to be some things that are not relevant for the PPH patient and some things for the PPH patient that are not relevant for the trauma patient. As we go along, we're going to be referring back to the HPCSA clinical decision tools, as well as our in-hospital teams who are going to hopefully give us a little bit of some thought process around what is different for the hospital spaces. Also, just a reminder that this is a conversational space really designed to share experiences, thought processes, and grow together, learn together. So, anything that people share, please take it at face value, but also understand sometimes the stress that comes with putting their hand up in a very public forum. We're here to kind of support each other and figure out how we make our systems better rather than take systems down. And the intention is also to unsilo emergency medicine. So we are hoping to build some experiences from the pre-hospital, in-hospital, ED, and then critical care and surgery spaces. So please feel free to jump in and share some experiences. We'll try and tie those experiences back to what the guidelines, what the evidence says. And there may be some things that we don't always have evidence for. And for those things, we'll use best judgment and thought process. So, joining us today, we're going to be having a sort of conversation between Tash and myself, bringing in some of the Rocket team. And this session is going to be sponsored by Lenmed eThekwini Hospital. So, we have Elena joining us with some of her nursing team. And I'd love to just hand over to Elena if you have anything that you want to sort of start us off with.
Hi, Caleb. Hi, everyone. Thank you for joining today. We don't have anything to present. I guess our nursing team is just looking forward to the discussion later on. But yeah, we're ready to go with Caleb when you are.
Amazing. Thank you guys for joining. So I guess we're gonna start out just with setting the scene. So the patient who is bleeding is a patient who is a super high risk patient, but is also a patient who is quite difficult to manage, especially in the resource limited setting. So I guess I'm gonna start off with a question, and this is gonna go to Tash, and then I think to the bigger team, and then into the nursing teams. When you walk into chaos, when you are sent to a patient who is bleeding, what are some of the things that kind of go through your head, and what are you thinking about to prepare and plan for this patient?
Morning, Caleb. Morning, everyone. So my very first thought process would be, do I see significant bleeding? So do I see any life-threatening bleeding? What can I do to control it? And what is the perfusion state of my patient at the moment?
Awesome. Any other thoughts from the bigger team? I think Karen and Chris are on, and then we also have a few from our bigger team, JP, who's joining us from Canada. Karen, go ahead.
Yeah, hi, good morning. Yeah, so I fully agree with Tash. I remember doing a call, and I think if Peter's on here, he'll remember it as well, a buffalo attack that we did. Um, Patient was, yeah, if you can think of a buffalo attacking a human with those horns, my thought was, oh God, what are we gonna do? Um, and it was pretty much the same as what Tash has just said. Control the bleeding. Um, I know that I had started with sort of the hemostatic dressings and all of that to control the bleeding from the wounds. And Peter, I think he was also in the same mindset and getting up IVs and thinking about TXA and how are we going to stop all of this bleeding from all of these open holes, and then also not knowing, because we're out in the open and on a game farm, how are we going to know if this patient has got, obviously besides the evidence from vital signs and patient condition, but internal bleeding. So it was just, get the hemostatic on, get the TXA in as fast as possible, and get him to surgery. So yeah, it's quite a hectic scenario.
Awesome. Thanks, Karen. Cool. So I think always, and just like Tash and Karen mentioned, we've got to be thinking about how can we stop blood from pouring out of this human being. Otherwise, we're going to end up in the situation where we're not going to be able to manage that patient over the long period of time. Maybe we can move across to, I know Chris and Gilbert are sitting in usually remote sites. What changes for the remote site medicine approach, if anything changes? Chris, go ahead.
Okay, morning, Caleb. Morning, everybody. I think one of the main issues that comes up in the remote areas is the fact that you stuck with this patient for a few hours usually, and there are no blood products available. And that really makes it more important to stop the blood loss as soon as possible, because you don't have any products to give to this patient to top up what he's lost.
Awesome. So just probably duration of care and the stress that comes with having to manage this patient over such a long period of time.
Yes, for certainly.
Awesome. I'd love to pop into any of our teams who are working in facilities. So Elena, maybe you and your team first. What changes from your perspective? And then we'll pop back to JP. Okay, we'll see if we can get Elena to jump back on. JP, I see your hand was up. Sorry, I think I got knocked off. JP, I see your hand if you wanted to share something there. Marianne, do you want to go ahead?
Hear me properly.
Yes.
Hi, can you hear me?
Yes, we can hear you.
Excellent. Sorry, bit of a delay.
No worries.
Well, I used to work remote, and what you find is when you're out there and you're alone and you're not just dealing with the now, you're dealing with what's ahead. As the other paramedic said who's working remotely, you have to think ICU, you have to think flight, you have to think aviation, you have to think in cellular oxygenation. So you're not just dealing with the here and now, you're dealing with absolutely everything. And your brain has to think not just in a linear way, but in a whole, in one big picture. Everything's just flooding your brain of what's going to happen, what's happening with the patient's body down at cellular level, how's it going to impact all the other organs, etc. So yeah, that
I love
was
this. So sort of thinking really big picture. And I think that echoes really nicely with what Shauna said on the chat, just in terms of we're not just thinking about stopping the bleed, but we're also thinking about perfusion of the brain and later the kidneys. And then how do we get this patient to the right help to maintain those things? Kind of on the same line with you.
Yes, and also not like the other lady said, is what do we do now? to understand you don't have time to mess around on scene. You cannot do surgery on scene. You have to get them to a appropriate facility and move it along as quick as possible.
Cool. So another big thing that pops up is going to be time, and that we're going to come back to over and over again. I wonder if there's anyone from the in-hospital space who wants to share maybe what's different between the in-hospital and out-of-hospital spaces, specifically around the next layer of care. What are you thinking about when this patient arrives to your hospital?
Focal.
Somebody thinks nothing. That's scary. So JP just sent me a message. I think he's struggling a bit with being able to speak, but he wanted to mention a case when driving on the way from holiday where he was more than just a first responder with almost nothing, where a patient had bled a lot and had a very low level of consciousness, and really he's added in for his sort of big picture thought process is praying, because without much equipment, there's not a whole lot that can be done. I want to move back to Tash, and I'd really love if you could take us through what the sort of ITLS thought process is around how do we control this external bleed? What are some of the data and evidence that we have available to us, and what is the big picture?
So the first would be to compress the bleed. So we would hold pressure. That would be our first course of action, and then, well, direct pressure, and then we would move on to tourniquet if that fails. From there, we would move on to our hemostatic dressings, our gauze, pelvic binders if we're concerned about our pelvic fractures, our splints, which we would obviously use to reduce any bleeding. Yeah. So I think that would be our first port of call. So our direct pressures, our tourniquets, hemostatics, and our pelvic binders.
Awesome. And I think that there are a few people in the call who have recently had to use tourniquets and direct pressure. I don't know if there's anyone who wants to share an experience, what some of the challenges were, and where some of the barriers are to applying the tourniquet. I see Special Ops has put their hand up.
Hi, it's Chris Morris.
Hi.
How's everybody? Good.
Good.
Good. So I had a case towards the end of last year, quite a good bilateral partial amputation tip fib MVA. Was a truck driver, and we'd extricated him, and he had started having massive hemorrhage on those partial amputations. Tourniquet placement with that was a challenge because, they always tell us to do like 2 inches above or, as close to the bleed as possible so that we can preserve limb. He had an issue because that was literally everything below the knee was compromised. So if you place it just above the knee in the popliteal sciatic region, you get Hunter's canal. And no matter how hard you tighten the tourniquet, you're not going to stop that bleed. So you have to place the tourniquet more proximal, higher up on the leg to really occlude that femoral. And I noticed that. So I started applying on the Hunter's canal. I wasn't aware that that this was going to be an issue. I tightened, nothing happened. And then I realized this is not happening. I remembered high and tight, went up high and had much better success. Some other things that I've just recently come across, I did some more research on it, and a lot of evidence coming from the Ukrainian perspective is indicating not who needs a tourniquet, but who doesn't need a tourniquet. Identifying actually the life-threatening hemorrhage compared to, just the normal gunshot that's bleeding a little bit and people throwing tourniquets on, compromising limbs. So I found that with my experience with that Hunter's canal situation, it really did come down to like recognizing that what you're doing is not working, and then changing your approach. Yeah, that's all I have to add for now.
Really nice summary. So I wanted to also just pop a picture up here. This is a picture of some improvised tourniquets. And I think really important just to chat about tourniquet placement and again, coming back to when is it not indicated? And I think if we're worried about a massive bleed that is going to be a life threat, we should absolutely be applying tourniquets. You can see in this image, the team who were treating this patient were not medically trained, except for some very basic first aid. And they had obviously figured out that this patient was bleeding quite extensively and had applied some makeshift tourniquets and had done, I think, a relatively good job. But there are some challenges with this makeshift tourniquet, and I don't know if anybody can spot some obvious problems with this tourniquet.
Well, obviously, it's not wide enough. It's very, very narrow and could actually cause quite a bit of damage.
Cool. So the width is really important, not just from the perspective of damage, but also from the perspective of pressure over big areas to try and stop the bleed. Estienne?
Yeah, another thing on this is that your pressure that you can't lock off your winch, if you want to call it that, with the screwdrivers in the picture. You'll have to have someone hold that to keep and maintain the pressure on that winding pressure that you're trying to build.
Awesome. So to overcome that, one could put a second sort of bandage once you've got the tightness that you're looking for. But again, that the width of this tourniquet makes it a little bit less reasonable. It did seem to slow down the bleed, which to the team on the scene's credit definitely helped to prolong the amount of time available to keep this patient alive, and is awesome. Is better than the nothing that was there before. Any other challenges with this tourniquet? Risa?
Hi, so from my side, they're using, obviously we can tell that they're non-medics and they are using what is available for them. But the fact that we're using 2 sharp screwdrivers might be a bit of a concern, because if we do happen to move the patient in the wrong way, we can get the screwdrivers actually stabbed into the patient's leg, and obviously unintended, but that would be something concerning from my side.
Definitely something to worry about. Chris, and then Chris.
Yeah. Sorry. Just one thing I wanted to bring up. One thing I often encounter pre-hospitally is when you arrive on scene and, there's these, like a mass shooting or massive hemorrhage or something, the patient is often not adequately exposed. So it's often a guessing game of where the bleeding is coming from. So I always like to advocate this whole trauma naked, expose the patient completely. You have a much better idea of what you're dealing with. So, yeah, so from this scene, I can see that, they haven't exposed the full leg. It would be much better if we could have a better picture of what we're dealing with.
Definitely. So being able to actually see the injury and the issue. And again, just the height of the tourniquets, it may be better to go higher sometimes than to go lower. In the ITLS space, we speak about go high or die. Other Chris, and then Karen.
Okay, and my point was also just the positioning, that they should be a lot more proximal in this case than what they are.
Cool. Definitely a really valid point. Karen.
Yeah, just also, I mean, they used what they had, but also the material of the tourniquet is maybe too elastic, maybe not holding the pressure that it needs.
Really good point. So the material of the tourniquet should be as non-stretchy as possible so that we could really apply good pressure instead of losing the pressure over the stretch. Really good point. I see there's a note also just in the chat around what about using a blood pressure cuff for the tourniquet? What do you guys think? Anyone with experience on a BP cuff for a tourniquet? And maybe some of the rules that go with it. Sean, go ahead.
I just want to add, I don't have not to answer the BP cuff related question, but I wanted to just throw something in there, and that's that we're talking about the high placement for the tourniquets. Funny enough, some of our military in the military setting, they actually have built-in tourniquets to their pants, and the built-in tourniquet is actually pretty much almost all the way up at the junction, especially in the legs. So if you think about it being, super proximal, so there's obviously reason for that. So I just wanted to sort of add that.
That is amazing. I think that is something that you'll only see in the Middle East where you guys are. That is the coolest thing, tourniquet pants.
Yeah, I believe it's actually an American thing, but we've obviously adapted it and can afford to do it, But it is something that, I mean, it speaks to this high tourniquet placement almost immediately, even for sort of what would be considered the lay person,
That is so cool. Andrew.
Hi, Caleb. Hope you guys can hear
Hi.
me.
Can.
Kevin, the other name.
Oh,
So just in terms of manual BP cuff, I've actually used that once or twice before. And I used it in the term whereby, as a student, when I saw they were in theater, they actually use a similar case where they use I don't want to call it like, it's similar to the principle of a BP cuff, but it's basically a manual inflation cuff, whereby if the orthopedics are using a particular limb, they use that pressure cuff to basically tourniquet that limb. And that's where I picked it up from initially. And in terms of effectiveness, unfortunately, you have to push that BP cuff very high. So sometimes what can happen is the actual Velcro comes loose. So that's just one thing to consider. But in terms of maintaining that bleed to stop, it was quite effective.
Awesome. And I think it hits kind of all the outcomes for a good tourniquet. It's really nice and wide. It applies pressure over a wide surface area, and circumferentially it is controllable in terms of pressure. You can obviously pump up that pressure beyond the systolic blood pressure so that you can overcome the bleeding. And it is removable when you need it to be removable. So I think it is a good idea. There are just some rules around. Once you have applied that tourniquet, you are going to need to keep eyes on that pressure gauge just so that you're not losing pressure. And some of the places speak about actually tying off the limb that inflates so that you can't lose pressure. Also a really valid point around the Velcro. If it's going to come loose, it's not going to be very helpful. So it must be a relatively new blood pressure cuff and not one from the 1970s. Marianne. Marianne? There you go.
Off my hand up. My apologies.
Oh, no worries. Okay, just some notes from the chat. Danielle's also just mentioning the mast suit. And so probably not the older mast suit, but probably the new non-pneumatic anti-shock garment might be something useful. Obviously doesn't work as a tourniquet, but may be helpful for that patient who has sort of widespread or wide trauma, and then definitely in the PPH patients. We'll come back to that a little bit later. I wanted to move on to just something around tourniquet use, and that is it is flippin' painful. So I don't know if anyone has had any experiences of patients with a tourniquet on, and sort of their experience around increased pain management requirements, and their approach maybe to that pain management. Ronnie.
Yeah, good morning, Caleb, and everyone else. Speaking out of experience working for the latter part of about 12 years in hostile and austere environments, spending 5 years in Somalia with the small medical operations group. The essential thing with tourniquets was to teach military staff how to use the tourniquets properly. And to teach a soldier medical terms and stuff didn't work properly. So we worked under the TCCC guidelines and taught him with that of the high and tight. So whenever we would get into a situation where a tourniquet was placed and I got to the patient, or where the CCP was, the patient was brought to the CCP. It was our work then to convert that tourniquet, if it was necessary, to either hemostatic dressings or direct pressure or whatever. And I can tell you that I've seen very funny stuff on how to, especially with auxiliary bleeds, how to package that wounds and how to keep it in place and how to apply the pressure. So the high and tight under the TCCC guidelines is a good thing, and it works for people that doesn't really understand what the effect of the tunica is in the long term. Thanks, Caleb.
Very nice. Awesome. So yeah, I think just the learning in the life-threatening environment is as high as you can, as tight as you can, stop the bleed, and then you buy yourself time to figure out the next step. I did want to run through just a few of the like some of the myths that I think are still out there, especially in sort of basic practice. And that is just number one, that tourniquet should only be used as a last resort. And I think this is absolutely not acceptable. It should be used when the patient has a life-threatening bleed that you can control peripherally with a tourniquet. And that will buy you time to figure out the next step. Just number two, if you use a tourniquet, you're going to lose the limb. And that is also incorrect. We have a fair amount of time once the tourniquet has been applied. Some of the spaces are speaking about up to 8 hours before you start really worrying about the limb. But also, you didn't put the tourniquet on for fun. We put it on because the patient's going to die from bleeding. And so the loss of their limb would be way secondary to the application of that tourniquet. Myth number three is that a tourniquet should be released every 2 to 3 hours. If the bleeding stopped, the tourniquet can be removed. So just remember, you placed the tourniquet because the patient was dying from bleeding. It comes off when the patient's bleeding can be managed. So you're in the presence of the surgeon willing to manage the bleeding, or you're in theater. If a device has to be removed for transport, like if you're in a theater and moving a patient to another environment, it must be replaced before the manual device has been removed. And I think sometimes we see, okay, the bleeding stopped, and that's great. It stopped because you put the tourniquet on, and potentially because the patient's blood pressure had dropped to the point where bleeding was not going to continue to happen. But once that tourniquet is on and doing what it needs to be doing, and we're resuscitating that patient, there is the risk that the patient will bleed again. So don't take it off. If you've put it on to keep the patient alive, keep it on so that you can keep them alive. A tourniquet placed correctly will not cause pain is another myth. That is nonsense. Tourniquets hurt. I had a patient with bilateral, sort of really open mid-shaft femurs, bleeding out from those fractures. And once we applied the tourniquet, he actually said to me, please just take it off, I'd rather die. So we have to be really good with pain management, and probably something procedural so that the patient doesn't try and remove the tourniquets. Once you've got a tourniquet on, obviously, it's a little bit easier to manage that pain management because blood pressure will be a little bit less of a ridiculous risk. And then myth number 5 is a makeshift tourniquet is as good as a purpose-made device. This is not correct. A makeshift device is okay because it's better than the nothing, but it must be replaced with a properly placed, purpose-made device to maintain constant pressure. So just in summary around tourniquets, it is first line in a life-threatening limb bleed. It should not be removed unless you're ready to control the bleed. Pain management is really important, and the tourniquet does not really increase the chance of limb loss, only the chance of surviving a massive life-threatening bleed. Estienne. Estienne?
Apologies, can you hear me now?
There we go. Yes, we can.
Apologies. I had a patient with a popliteal artery rupture that was clamped internally and intubated, ventilated from, it was a 3-hour transfer. And we struggled so much with managing the patient's pain that the sedation was just not enough. We had ketamine on board, we had morphine on board, we had dormicum on board, we added fentanyl at some point. So just to bring that point through, that even an internal clamp with that lower limb not receiving any perfusion is severely painful. Adding on a tourniquet with that external pressure that you have around the skin and around the tissue and muscles, pain management is really, really something important to manage.
Yeah, thank you for that. And it's just something that pops up over and over again. It's just really good pain management. I saw Kulani, you had your hand up. I don't know if you want to add in.
Hi, Caleb. Thank you. Yeah, I think what I wanted to touch on, especially with the tourniquet, is the pain part, which I think the previous speaker touched on. But I also just want to share some experience I've had of treating this patient, especially on the streets as a what do you call the name? As a good Samaritan, where you don't have all these gadgets or anything. So I've had few cases where, especially the limbs that were bleeding so profusely, no matter what we use, it couldn't work. But what I found working, and it's something that we can try, especially if you are unable to stop the bleeding with a tourniquet, is to directly compress the major artery. So let's say the bleeding is in the lower limb. You can directly compress the femoral artery, or if it's in the upper limb, you can compress the auxiliary artery. So that will completely stop the bleeding from the artery. So even if you have applied the tourniquet, or if it's painful, you have to loosen it a bit. If you directly compress the major vessel, it almost always stops the bleeding completely. Yes, you can have some minor bleeding from especially the venous side, but it won't be as significant as you have stopped the major one in the bleeding limb. So even during transport, if you find that you are unable to stop the bleeding, if you just put your 2 fingers there, you can almost be certain that you can get to the destination before the patient exsanguinates to death.
Really awesome point. And I think that that also comes across in the one question that I saw in the chat, which is, can you not use tourniquets and Celox or hemostatic agents? And I think this is really important. You don't have to choose one measure. You can choose all the measures, but if you've got that massive life-threatening bleed, slow it down with a tourniquet. Apply your pressure, apply your indirect pressure, and if those are not working, adding in the Celox or adding in one of your hemostatic agents will also be helpful. Obviously, it's better to get the hemostatics on as early as possible because the clot formation onto that hemostatic will be ideal, but it's not always practical because sometimes it is something that you have to open and you have to find, and then by the time you get it on, the patient's bled another minute or two, and it makes it a bit challenging. Chris?
I came across quite a nice quote the other day. They say that 100% of patients who receive a tourniquet after the onset of shock or signs of shock, they demise. On the inverse, 100% of patients who receive a tourniquet prior to the onset of shock symptoms survive.
This is really cool. Actually, it lines up with a podcast I listened to not too long ago around administration of blood products in the pre-hospital space, and exactly the same sort of outcomes. By the time your patient is heading towards cardiac arrest, blood is useless. But if you can get that blood in, and I guess the tourniquet is exactly the same, before your patient starts to deteriorate, you have a really good chance of keeping that patient alive. Cool. I think we have exhausted the tourniquet chat, unless there's anything burning that anybody else wants to jump in and add. So the next sort of thing that I think we need to chat about is going to be once we've stopped the bleed, then what are going to be our priorities around getting that patient, first of all, as stable as possible, but within the constraints of hypovolemic shock, and then what does that look like? So from the pre-hospital space to the in-hospital space, what are some of the things that we're thinking about and what do we need to get right? I saw a hand go up super quickly and then went down again. Danielle, go ahead.
Hi there, can you hear me okay?
Yes, perfect.
Yeah, so what I found helpful, we had a Good Samaritan bystander on a bilateral partial amputations, traumatic amputated penis as well. And what I did was, while we were busy stopping bleeding, putting up IVs, all of that, managed to get photographs so that they didn't have to undo everything when they got to the hospital. Also inform the hospital. So they were ready for us. They didn't have to undo everything to look at the wounds. And I found that helped the patient a lot.
Such a nice idea, especially if there's enough hands on scene to be able to do that. Gilbert.
Yes, Caleb, thank you. So I wanted to just throw something in. I know it's not something that's currently in practice, and maybe decade from now, it might be something that we see coming in. And it's something that we did on one scene where we did it manually with hands, where we tried to do intra-abdominal compression, so trying to truncate the aorta with fisting. And I started looking at that, and actually there is a commercial device which is an abdominal tourniquet. It's quite super expensive, but I'm sure in a decade from now, Chinese will come with a cheaper version. But while we're talking about the tourniquets, because looking at tourniquets mostly on compressible beads, like in extremities, but also in non-compressible beads like the abdomen and things like that, it's something that we should think about. And there is actually an abdominal tourniquet that is probably right now only in the military or American spaces because of the pricing. And maybe in a long future, we might see something like that coming in, and also coming in the ITLS space, being something that we do for non-compressible fluids.
It's definitely something that's been back and forth in the evidence, but we don't have great evidence for it. But I think mostly because no one has access to it. I wonder if there's anyone on the call who has access to the junctional tourniquets and is maybe using them in their practice. Ronnie, go ahead.
Yeah, okay. Once again, we had access to them in Somalia, and what we found, it wasn't very great. You can't really control the bleed with auxiliary tourniquet or abdominal tourniquet. It does lessen the effect a little bit, but there is no great evidence to show, like you say, that it works properly.
Yeah, so what I've seen from the evidence, they are crazy expensive and maybe not always super functional. But I think maybe in the right patient with the right sort of mean arterial pressure, it may add something. Any other thoughts on the junctionals if you've used them in practice? Cool. I don't think not a lot of us have experience with them. Sean also just mentioning that there are some new functional femoral compression devices that are new, and maybe we don't have so much data about. Sean, I don't know if you guys have them and maybe want to share some experiences.
Yeah, so we do we're kind of somewhat trialing them at the moment, but to be honest, the results seem to be up and down. I mean, the company's obviously selling their own personal sales pitch and how effective they are, but what we've kind of seen based on some of the conflict that's ongoing at the moment, that there seems to be quite a mixed bag of results coming out with them. So I think it's sort of the same as the abdominal tourniquet sort of field. We're not actually sure how effective they are, you know.
Awesome. I mean, I think it just kind of comes back to that constant reiteration that the basic stuff that works is the stuff we should really be spending our time on until we've got better data. Anis.
Good morning, everyone. Can you hear me?
Yes, we can.
Hi there, man. Listen, okay. The after management, I don't know if I should have brought it up earlier or actually now, but normally when you get to a scene, then there's like multiple staff members, actually medical staff members, trying to stabilize the patient. And you'll find that it might be 2 or 3 guys with multiple amputations or just bleeding all over. Everyone is trying to apply a tourniquet. But who sits at the end of the day to actually double check or actually just oversee that everything has been applied properly? Because what I've noticed on 2 occasions is that everybody thinks that they have applied the tourniquet properly, and then while you actually load the patient en route, the patient is still decompensating, and then you'll find that one of the tourniquets has not actually been applied properly. Addressing that, who takes charge? Because now, like the lady also said, you take pictures. I don't normally do that, but it sounds like a great idea. But then at the point of having so many guys around the patient and one service is loading that patient is bleeding out and you couldn't actually find it because we just wanted to get the patient as soon as possible or from the floor onto a stretcher and into the ambulance.
It's a really good question. Ronnie, I don't know if you have an answer to that or another question.
No, just to link up with Anis, and it's a very good point, Anis. Caleb, I appreciate the March algorithm that you've put on at the beginning of the session. It's always, always have to go back and reassess. Always have to go back and reassess. So as soon as you finish something, you're back and you reassess, especially that lymph or wherever you've put the tourniquet on, you have to reassess every time. You cannot leave it. It will start bleeding again. It will lose tension. You have to maybe apply another tourniquet. But yeah, you always have to go back and reassess.
Also, just remembering that obviously the tourniquet is an intervention that's hopefully going to improve mean arterial pressure just by stabilizing the loss of blood. And so once we've done that, you may have to retighten the tourniquet even though it worked initially because the arterial pressure has gone up, and so bleeding may continue. So it's not a once and done. It's just like Ronnie said, you are assessing in the unstable patient literally every 2 to 5 minutes to make sure that all the interventions you've done are still doing what you expected them to do. I wanted to go, there was a really nice question in the chat around exposing the affected limb to low environmental temperatures in prolonged tourniquet application to delay muscle damage. Just from the thought process of how important hypothermia is, I'm not sure that there's great evidence around that. And I'm also not sure that we're super worried about damage to the limb when we are aggressively trying to treat the potential death of the patient. So probably just better to keep that patient warm, keep the limb as comfortable as possible. Obviously, the core temperature drops, you're in big trouble with these patients. Which leads us really nicely into a concept that I think has been bouncing around. Guys, if you're not talking to us, please mute yourself. Which brings us into the concept of the diamond of death. So I'm going to ask Tash, if you don't mind taking us through this concept and sort of how it applies to our practice.
Thank you. So I think we're all familiar with the diamond of death. It used to be the triad. And then in recent years, we've had calcium added. So the diamond of death historically was acidosis, hypothermia, and coagulopathy. And then with calcium being added, telling us that critical calcium levels or calcium being reduced, hypocalcemia, it's critical for platelet adhesion and platelet formation. So the function of in clotting factors is affected by hypocalcemia. And it also worsens our acidosis by way of contractility and vasoconstriction. Hypothermia, we know, a patient with core temperatures less than 35, bleeding is worsened and outcomes worsened in the colder patients. And it reduces platelet function. Acidosis, our patients with lower pH, acidosis caused by poor perfusion, poor tissue perfusion leads to our anaerobic metabolism, lactic acid buildup. And obviously we worsen that by infusing our fluids. I don't want to read through the whole thing. I think that we open that to discussion.
Awesome. So just two things that I've come across recently that have really focused my practice in the bleeding patient on trying to get these things right is, one, the more acidotic your patient is, obviously the worse they clot. But what does that mean? And so just in some reading and some data analysis, it looks like when your base excess drops to anything more than like -15, which is obviously really high, but obviously there's sort of a scale in between. By the time your base excess is at -15, you have lost 50% of your ability to clot because your clotting factors, your platelets, and all the things that sort of create that clot work well when they are in a normal pH range. And as soon as you become super acidotic, you really can't clot. And then on the other side, temperature or core temperature of less than 35 degrees also obviously creates the patient who can't clot and can't keep those clots in place. But here also just something really important, a drop in temperature in the trauma patient of for every 0.5 degrees is associated with an increase in mortality of around 25% per 0.5 degree. And so when we're talking about a patient who's sitting at 36 degrees, if you drop down to 35, you already have a 50% increased chance of dying from that bleeding injury. If you hit 34, you're basically sitting at 100% chance of dying if you've got a major bleed. And especially if you've got a major bleed that is uncontrollable. So there's no place to put a tourniquet, or it's an internal bleed that you can't control. And this is something I know that we do horribly in the pre-hospital space. We are so bad at maintaining core temperature, and not just because we forget about it, but also because everything we do cools that patient down. We expose the patient to get a better look, to manage the bleeds, to assess the patient appropriately, and then we forget to recover them. We forget about covering the patient from the back, so insulating that patient against our cold equipment and the environment. We give the patient fluid, which even if it's warmed, can't be maintained at that warm temperature. And so even if it's warmed, we're giving it at a temperature much lower than body temperature. We do a whole lot of stuff that exposes this patient to hypothermia. Plus, they've got the trauma injury, which immediately predisposes them to a hypothermic state. And so we're really just fighting a losing battle if we're going to forget about temperature, and if we're going to forget about what we give in the bleeding patient. Any thoughts, comments? Maybe this is a good time to pop over to the in-hospital space. Elaine, I don't know if you are able to unmute. How do all of these things that happen in our pre-hospital environments, how do they affect your next level of care for that patient and the next step in their management?
Hi guys, we're from Lenmed eThekwini Hospital in Durban. And so I'm the emergency department manager, and it's actually getting pre-notification is always such a great help, because that prepares us to also prepare theatre. One of the improved benefits we see is when you have a tourniquet, it also helps us plan better in terms of understanding limbs or getting vascular surgeons involved early. But immediately in the emergency department, knowing that you have a tourniquet applied gives us time to prepare for obviously clamps and all of that that we may use in the emergency department. Yeah, so yeah, I'm not sure if anyone wants to add anything else.
Awesome. I think that's so important, is this idea of pre-notification, which is sometimes really difficult, but is really worthwhile if we can get it right.
Yeah, and then obviously fluid resuscitation in terms of managing that pre-hypovolemia stage, that also helps. And I see we're talking about calcium and all of that, and we've seen some great interventions from some of our EMS, so thanks.
And Caleb, just to add, we also have lots of stress in hospital, especially when it comes to emergency blood.
Yes.
Like when any case comes through and that has excessive bleeding, we probably have excessive stress at the same time, because there's only 2 units of emergency blood in ED at any given time. And if we know what cases are coming in advance, at least we can preempt that order, or we can get more blood on site. It's a national shortage, you know how it is. So yeah, I guess the communication with all the teams, it really helps. And what Henisha said about theatre availability as well, that also comes into play, especially after hours. We need to call out a theatre team. And if we know that the patient's going up to theatre, at least that time on the road is used up while the patient's being stabilized in ED. So you get the team out at the same time, the surgeon's running through the hospital. Okay, hopefully he's driving.
Yeah.
Hopefully he's not running to the hospital.
Yeah, but it's just nice if we have the communication. I see, like, of late, we have like a trauma activation group now, and the team of paramedics that's on board informs us at least 30 minutes prior once they're packing the patient on scene. The trauma surgeon's also on the group, so she's already giving them pre-hospital instructions of how to stabilize the patient before the patient comes to ED. But at the same time, ED is aware of what we're getting, theatre is aware of what we're getting, and holistically, everybody's preparing, including ICU, preparing a bed for the vent. So just a little one WhatsApp group. I know we all love WhatsApp groups, but this one WhatsApp group's really, really working?
I think because most of our EMS, I mean, you're all from different areas and different provinces, but establishing that sort of communication with your emergency department, really, if there's a simple setup like that, it definitely helps with the outcome of that patient, because you saving time a lot of the time.
Yeah, so I was just going to add that actually is if our EMS teams have the ability to create those kind of networks, it really puts the patient first. And then obviously the team who are receiving the patient and the theatre team who need to be ready in the next 20, 30 minutes are able to actually get there and then do the things that they need to do. I did want to just jump in on fluid management, which I think we could probably spend 4 hours on. But maybe just some thoughts around fluid management. When we've got that massive bleed or that uncontrollable bleed, what are the guidelines? What should we be doing? What should we not be doing? I'm going to jump over to Tash just for the ITLS sort of trauma approach, and then to see if it lines up with what our actual practice is.
So I think the most important is that we have moved away from the 2 large bore IVs, bilateral IVs, and we just run it open. I think the way that if you're as old as me, we've all been taught. We need to target specific maps, and that's obviously based on whether we're dealing with abdominal bleed, whether we're dealing with patients with TBIs. So we need to look at the clinical profile and then decide what map we're targeting. And I think as a standard, we're looking at targeting a 20 mils per kilogram instead of, boluses of a liter or a 2 liter. So we need to really move away from the old practice.
Awesome. And I think also really important just to maybe have some targets in our mind about what is acceptable. I don't know if there are any thoughts around what is an acceptable map that we're looking at. I think someone's put up a message just to say permissive hypotension. Monique, what do you think? What does permissive hypotension mean for us? Any thoughts? Let me try and sort out your muting problem, Monique. But if there's anyone else who wants to maybe add in while we sort that out. What are the kind of numbers that we're looking at? What are the clinical picture that we're looking at? When does it change? When is it not reasonable to apply hypotensive resuscitation to the trauma or the bleeding patient? Yes, go ahead.
Mornings, can you hear me?
Yes, we can.
Awesome. So we actually had a chat about this yesterday with the Western Cape Metro CPD event. So the idea is to apply it when you know you can get the patient to definitive care, meaning a facility that can actually perform damage control surgery. So that is the whole idea. So in terms of numbers, I think it varies. With the TBI, it's always a map of 80. Without the TBI, you can target lower maps. I think some research actually says like between 45, 65. Those are acceptable numbers. And the idea is to not overload these patients with fluids and actually popping clots to facilitate clotting in these massive hemorrhage patients. But the issue comes in when you are not taking the patient to a facility where they will do like damage control surgery. So then it becomes a bit difficult to keep this patient with low maps. And then you go about an hour or 2 hours from a facility that will do damage control surgery, and then the patient will die anyway. So yeah, it becomes a game of balance.
Very nice. And I think you've brought the nuance so well into the picture, in that we can't really pick a number, right? We have to be approaching each patient specifically and figuring out what are we trying to achieve with that patient. If we're going to a trauma center where they're going to be going straight into theater, then a map of 45 for an hour might be reasonable. But if we're taking that patient to a center where we may not have access to surgery immediately, then a map of 45 over an hour or 2 or 3 hours may put that patient at risk later. And so then maybe a higher map is better for that patient. And I think just in terms of numbers, a map of 65, if we just think about sort of the blood pressures, a map of 65 is kind of like passing matric with 33%. It's a good start, but it's definitely not somewhere where we want to end. And obviously it depends on the patient. So we said the TBI patient, a map of 60 is definitely not acceptable. But a patient who has a massive abdominal bleed, a map of 60 might be just enough to keep them alive, depending on where we can get them. Ashraf's made a really nice point just around fluid management, and that is being really careful not to overload patients with fluid and cause hemodilution. And that sort of fits into that diamond of death really nicely. So I think the answer on fluid is the least amount of fluid for the point of keeping the patient perfused so that we can get them to the next layer of care. Obviously, the patient has lost blood and so probably needs blood replaced. Probably doesn't benefit very much from fluid replacement unless it's going to stop them from dying, which would be very helpful. So small fluid boluses, really carefully titrated to perfusion state that sort of makes sense and keeps the patient alive. That's as close an answer to a number as we're going to get. There are some other agents, though, that we could use apart from fluid. And I don't know if anyone in the pre-hospital space is carrying them or keeping them, but if not, then we could definitely pop over to the hospital team just to chat. I think we did chat a bit about blood, but there are some other agents and items that we might be able to use to assist us in this massive bleeding patient. Any thoughts? Suddenly we've gone very quiet. Awesome, Lorato. So Lorato's brought up the idea of TXA. So while we're on that topic, how much TXA? So Chris is saying 2 grams. And then we've got someone else saying 1 to 2 grams. I'm just going to share the HPCSA clinical decision tools for the pre-hospital team. But I think it's also really helpful for the in-hospital team to be aware that there's not really massive consensus, except that we do know that we're probably talking about 1 to 2 grams at some point. So if we just have a look, this just speaks about the badly injured patient, but there's also the clinical decision tool for the shocked patient. And I just want to highlight as we move down into this block over here. So if you have a patient who has a systolic blood pressure of less than 90 and a heart rate of less than 100, or visible active bleeding, or decreased level of consciousness, then insert IV lines, think about some fluid. They speak about small volumes, 100 to 250 mils, titrating resuscitation to maintain a palpable carotid or femoral pulse, not using permissive hypotension in pregnancy, the aged, or the very young. And in the head injured patient, maintaining a map of above 80, all things we've spoken about. And then right here at the bottom, if there is active bleeding, give tranexamic acid 2 grams IV over 10 minutes. And the reason for that is just because I think we're really bad at remembering to do the second dose or the infusion dose of TXA. And there doesn't seem to be any additional harm in just giving 2 grams straight up. So just so the hospital teams are also aware of this should be happening in the pre-hospital space. We know that TXA given as early as possible are going to be way more effective than... Sorry, I just removed myself from the meeting. Later than earlier rather than later. And we know that for every delay of around 15 minutes of TXA administration, we are dealing with an increase in mortality. Somewhere between like 12 and 25%, which is a crazy amount if you think about it. I also just wanted to share maybe just an image around how TXA works, which is probably overkill. We have been using TXA for a while now, but there's still a misconception that tranexamic acid or cyclocapron is going to increase the clot and increase the amount of clotting that happens in the system. So just as a reminder, TXA really works to reduce the amount of conversion of plasminogen to plasmin. And plasmin is a substance in the blood that breaks down clots. And what happens when you have any kind of clotting happening in the system is obviously the body wants to return things back to normal as soon as possible. So once a clot is formed, it wants to break it down. And what TXA does is it stops that breakdown, which is not really helpful if we just talk about a small local paper cut. But when we're talking about a massive amount of trauma across multiple areas or big vessels, this is really helpful because every time we break down that clot, we need to build it up again to stop the patient from dying. And obviously, there's a point at which you're going to run out of the ability to create new clots. So for the massive bleeding patient, the idea really is to give that TXA within the first 30 minutes, if possible, of the trauma. Obviously, up to 3 hours is where it's going to have its effect. And then that just helps to keep any clots that are made present in the system. It does not increase the risk of PEs or any other clotting disasters, according to the data that we have, and seems to be something that is really helpful. Also, something that's come up is FFP or FDP. Thanks, Brittany and Gilbert and Durrani. Maybe we can go to our hospital team just to chat about the use of FDP or FFP. What are you guys using? Why do we like it so much? Very nice point just from Sean. You don't have to give TXA IV. You can also give TXA IM, especially in the patient where IV access is very difficult. Just a note then on the GI bleed, we don't seem to have great data on the use of TXA for GI bleeds. It does seem to actually increase mortality, and we're not totally sure why. Anybody using FDP in their practice or FFP? We're talking about the plasma options here. Ronnie, you mentioned it. Do you guys carry?
Caleb, yes, we used to carry it in Mali, but unfortunately we never had the opportunity to use it. So just before the contract closed, we received it, and yeah, we never had the opportunity.
Awesome. I know that in the rocket space we do carry, and then obviously start with the right patients at the right time. Anyone on the team who has been in that system using FDP, and maybe some of the challenges, some of the things that went really well? I know there are a few online who have used it. I'm not seeing a whole lot of hands. Oh, Brittany, go ahead.
Hi, Caleb. Good morning, everyone. So personally, from being qualified practitioner, I haven't used it pre-hospitally, but as a student, we used to use it quite often in the government sector of the hospitals. And what I found is it is very highly effective, but it takes very long to mix, FDP specifically. Just due to the fact that obviously it's fresh dried plasma, it's frozen dried plasma essentially, and it has to be mixed properly, and obviously to avoid clotting. It comes in these huge glass bottles, so they're quite bulky to carry around, I think, for us, especially in our little drug bags, and they take forever to mix. However, I do think they are very highly effective because they work via different pathways compared to our TXA, like you've mentioned, just prevents the breakdown of clots. So honestly, in my personal opinion, from seeing how well it works, especially in your hemorrhagic patients, I don't know why it hasn't been discussed on the HPCSA board that we can carry it, because I haven't really seen many negative effects on patients by using it. So yeah, it would be great to do it. It would be great to use. The only thing is, like I said, it takes long to mix. So you'd have to have a few extra hands and knowledge on how to mix it. pre-hospitally to use it. But yeah, that's just my opinion. FFP by itself obviously is very similar to blood products, very difficult for us to carry. They need to be kept at certain temperatures, and they need to be rotated continuously to prevent clotting. So yeah, that's just my opinion.
Cool. So I think it's always so funny that the EMS team say it takes so long to mix, and it can take long to mix, especially when you only have one person who is on the team. Our hospital teams don't find it too bad because there's much bigger teams and there's a person dedicated to mixing blood and blood product. Sean has also just mentioned FFP usually stored at room temperature, reduces the effectiveness, but makes it more stable and easy for us to use. And there is quite a bit of data around it and a really nice podcast. We'll see if we can find that podcast and send it on. In terms of blood and blood products in the pre-hospital space, definitely, well, blood specifically and whole blood, probably not something we're going to see. We can't even get massive units and numbers into our EDs, so it's going to be pretty difficult to have access to in the pre-hospital space. But if DP, freeze-dried plasma, I think is something that is as effective as FFP. If we have a look at the data, it works just as well. It is easy to store. It's relatively easy to manage if you have enough hands, and definitely because it carries some of the blood proteins and the clotting factors, is way better than just volume. So in terms of fluid, we're going to go to Elsa.
Hi, Caleb. I'm from Eswatini, so we're sitting with a different situation where blood or safe blood is not readily available. But I want to just mention something. There is a company which is locally in South Africa. Hemosaver it's a unit that's like a suction canister that can be in the facilities or on the ambulances, where you can collect the patient's own blood. You literally just suck it up in the canister. Obviously, you heparinize the saline that runs with it. And then if you do then take the patient to a facility that does have access to a cell saver device, they can wash it off and you give back the patient's own blood. So one canister like that can take up to 1.8 liters of blood. So maybe that's something that the EMS can think about, that you can give the patient's own blood back, and the cell saver the cell saver actually takes off all the heparin that was in the vaculator and all impurities, and you give back the patient's own blood with hematocrit values that rise more than with whole blood at the end of the day. So that's maybe something that the ambulance crew can look at.
It's a really, really nice idea. And there's also the concept of sort of auto-transfusing from chest drains and stuff like that, which is also absolutely reasonable, and probably better than the no blood situation that is in lots of our environments. Nice, Sean. I think you said the same thing. I also just wanted to come back to, there was a comment about Gelafusin. I don't know what the bigger picture thoughts are around the use of colloids. Super quiet. So if you have a look at some of the data around the use of colloids, what we know is that probably patients who are sick enough to get a colloid should probably not be getting a colloid unless that colloid is blood. We have some pretty good data around all of the synthetic colloids, that there is massive risk to kidney perfusion and also flow through the kidney, and that patients who are in the hypoperfused state do even worse in terms of their kidneys with the colloids. So I see a few comments just saying sort of it's better than nothing. It's probably not better than nothing. Nothing is probably better. If you can't manage the perfusion, then we probably need to be adding in an inotrope or a pressor. We should be thinking about small, frequent fluid boluses rather than one big fluid bolus. And unless your colloid is blood, probably staying away from colloids in general. Synthetic colloids are not ideal. I know that in the resource limited spaces, there's this concept that it's better than nothing, but just the manufacturers and the people who advertise for them will tell you different. But the data that we have available to us is that in the bleeding patient and in the septic shock patient, Colloids are probably not the best idea. Again, comes back to the most basic stuff: stopping the bleed, small volumes of fluid, TXA and or calcium, and then getting blood or blood products into that patient as quickly as possible. I see a comment there also just around using noradrenaline. And so if we have a look at some of the data, it does seem like might be one of the options, but not always readily available. So if we have to, it's not an ideal option. If we need for a pressor, then adding in something to keep that patient alive until theatre, but obviously with the intention of not overextending in terms of maps and looking for good numbers, but really just looking to keep that patient alive in the interim to get them to definitive care. I don't know if there's any other thoughts around that. We've spoken really nicely around stopping the bleed. We've spoken really nicely around managing temperature and how important that temperature management is. Blood and blood products. I don't think we're going to have a whole lot of time to chat about postpartum hemorrhage, but I do think this is something we'll probably move on to in a separate session, just because there's so much to talk about there as well. I think something that's also really important to maybe chat about is just the concept of airway management and ventilation. So anybody with some thoughts around airway management and the bleeding patient specifically? Tash, I know you have some deep thoughts about this.
Yes, please resuscitate before we intubate. Very strong feelings about that. Hemodynamic patients should not be getting tubes. It's not going to be the fix. And I think it's often a knee-jerk exercise.
Awesome. And I think that's something that we probably need to prime some of the trauma surgeons to, just that in our pre-hospital environments where we can't be opening that patient and sorting out the bleed, airway management is probably going to be the last thing on the list, because the bleeding patient doesn't do super well with either positive pressure ventilation or limiting negative pressure ventilation. And the reason why it's done in hospital is because that patient hopefully is going to be moving straight to theatre where the bleed can immediately be stopped. But in environments where that is not possible, paralyzing a patient in order to intubate that patient is not great, in terms of when a patient is negative pressure ventilating, they are creating what we call a thoracoabdominal pump. So they are using the chest negative pressure and the abdominal positive pressure, alternating pressures on ventilation, to create a sort of pump that increases preload. And when we then stop that immediate pump, we definitely risk blood pressure dropping all the way down. And then on top of that, we add positive pressure ventilation to a patient who has horrible perfusion state, and end up with the loss of both the negative pressure and then the addition of positive pressure, reducing preload and decreasing cardiac output on the other side. So as far as possible, where it's possible, moving to intubation and positive pressure should probably be a very last resort, and should definitely be supported by volumes, should be supported by adrenaline or noradrenaline, and should not just be done because it's the next step in the algorithm. I don't know if there's any big thoughts around that. Karen, go ahead.
Yeah, so agree with everything that's been said, and I also, Tash, I'm with you on that one. I think we need to just get over the fact, or over the thinking, that if the patient is breathing, the patient's fine. If the patient has a tube and breathing, patient's fine. Piece of plastic between the cords is not going to save the patient. If the patient doesn't have blood volume going around as much as the patient's on a ventilator, it doesn't matter. Yes, they're breathing, but they're not perfusing. So definitely resuscitate.
Very nice. Sean, next.
I was going to say the same thing. The reason that they're not oxygenating is not because they're not ventilating, it's because they got no perfusion. And it's literally as simple as that. Ventilating them more is not fixing the problem. They need better perfusion.
Very nice. I saw Helene or Helene. I saw your hand was up. I don't know if you want to jump in.
Oh, no, it was a mistake. You can continue.
Oh, no worries. And then, yeah, just some comments again, all around the same sort of stuff. I love that the sort of culture around intubation and the bleeding patient has slowly turned. 10 years ago, we would have had big fights about this, but I think sort of seeing the bigger picture and realizing why the patient is dying is something that we need to be really aware of. In terms of the bleeding patient, I think we've covered the vast majority of the things that we need to cover in terms of keeping that bleeding patient alive. I don't know if there are any other big picture things that we need to be adding or thinking about. Have we missed anything? Do we have any major blind spots? Maybe people in different environments see things that are slightly different.
So if I can add, just two things that often come up in training when we speak about blind spots. And I think this ties back to what we just spoke about now, the hypoperfused patient. One of the knee jerks that we see repeatedly is a SATS probe that is put on a patient that is hypoperfused, that is already shocked, and then getting fixated on oxygenation. So I think that's a pitfall that most of us here are aware of, but it's something that we keep fixating on. And the other thing is when we have a life-threatening bleed and we stop the bleed, we often fall into the trap of forgetting to do just a basic rapid trauma survey. And it's often not the critical things that catch us out, it's the basics. So getting back to something as fundamental as a proper trauma survey, you know, we get fixated on sorting out one injury and we miss the other thing.
Yeah, really valid point. And I think we also get like scared and surprised by the big thing and then forget about the small stuff, which is not always that small. Sean, you've made a really nice comment just around the use of end-tidal CO2 rather than SATS. Do you want to flesh that out for us?
Just that obviously, like it's been mentioned already, the SpO2 is picking up distally, and even if you're somehow getting it more centrally, you're essentially looking at something that's hyperperfused. Whereas end-tidal CO2, you're essentially looking at perfusion status because it's reliant on the blood flow that's returning to the lungs. So what we're seeing is way more centrally mediated response with regards to how is the blood pressure actually looking like.
And I think traditionally that end-tidal CO2 is like how we're ventilating. But I think what we need to focus on is exactly that physiology you've just spoken about, is the end-tidal CO2 only tells us about ventilation if the perfusion is intact. If the perfusion is not intact, it gives us so much data about perfusion. And seeing that end-tidal CO2 number come up as you aggressively attack the bleeding, stopping the bleeding, getting the fluid in, getting the blood in, that's winning. Seeing that end-tidal CO2 decrease over the interventions probably means we're not winning. And if you have the ability to measure end-tidal CO2 in these bleeding patients, even in the non-invasive nasal cannulas or polymasks, it is a fantastic idea. For the fact that we're going to know anything about ventilation, but for the fact that we're going to know everything about perfusion and whether our interventions are working or not. And rather than the number, the trend, using that trend to figure out where we are. And Sean, you've also made the point that end-tidal CO2 is immediate. So as soon as something changes in the perfusion, you will see an immediate drop in that end-tidal CO2, whereas our SATs may take some time to either increase or decrease. And probably more useful on the SATs is the pleth tracing than the number. But that's something that we don't all have access to. I think we've covered all of the concepts that I really wanted to cover. Tash, was there anything more on your list that we haven't spoken about that we need to speak about?
There's nothing on my list. I wanted to add, circling back to TXA, that while TXA is a great tool, I think that we need to remember that it's not a magic bullet, especially in the patient that's cold and acidotic and who's hypocalcemic. And I think we need to remember that without calcium, the whole clotting process falls apart. So even if we give TXA, it's not going to be the be-all and end-all if the body isn't in a state to make the clots in the first place. It's not about giving the right drug. It's about also fixing the environment so that the drug can actually work.
Really, really valid. We can't just give TXA and do nothing else. Awesome. With that, and I think the chat has been really nice today. Please don't forget to complete the register. It will be a word of the day will be bleed. Please make sure that you fill it in. And please leave us with some ideas around what else you want to learn, what else you want to know. And we'll see how we can get some more conversation and more experts to help us figure these things out. Thank you everyone for joining and have a fantastic day.